We're delighted to have Professor Fiona Lyons with us today. She's facilitating a webinar on navigating life after a HIV diagnosis, expert guidance and support. Professor Fiona Lyons is a consultant in the gum medicine and HIV medicine in Guide Clinic in St. James's Hospital, and she's also the HSE clinical lead in sexual health. You're very welcome today, Fiona. Over to you.
Thanks a million, Rachel, and thanks again, Rachel and Debbie, for the opportunity to present today. So I am going to, over the next little while, go through, sorry, I need to get my slide advanced. Okay, so navigating a new HIV diagnosis. And I'm going to go through what I think are the important things from a clinician perspective, but also trying to see it through the lens of the patients who we are providing care to. And actually, I was fortunate enough recently to speak at the conference for people living with HIV. So I kind of hopefully have got an insight into the things that are important for the people who are entrusted to our care. What I'll touch on over the next little while is a little bit about antiretroviral therapy, talk about the natural history of HIV, particularly outside of HIV with antiretroviral therapy, look at survival now in the context of effective antiretroviral therapy, and touch on areas that I think we're doing really well and areas where I think we need to do better. And then I'm very happy to take questions at the end if we have time. So I have no conflicts of interest to disclose to you. The only thing I will disclose is that I'm not living with HIV. And generally speaking, I tend to take a glass half full of type of an approach to the world. So I generally I'm of an optimistic disposition. So hopefully that will come across. And it's actually been my privilege and pleasure to look after people living with HIV since I was a very junior doctor back in 1993, working with my hero and mentor, Professor Fiona Mulcahy, who was the first consultant in genitourinary medicine in Ireland, appointed in 1987. So we'll look at a little bit of a timeline, first of all. So HIV, as some of you may know, was first described as a virus in the early 80s. And this arose from reports of individuals, in particular groups, presenting with very unusual presentations of opportunistic infections and unusual cancers. And there was the people who were seeing these people were saying there must be a link. There's something going on here. I wonder, is there an infectious link to this? And then that's what, on the back of that, HIV was discovered as a virus. So HAART stands for highly active antiretroviral therapy. And while it's a term we don't use too much now, it is very useful in the context of a timeline, because what it demonstrates is that pre-HAART, which was highly active antiretroviral therapy, actually antiretroviral therapy that really made a difference, didn't come about until the mid-90s. Prior to that, we did have one or two drugs that we'd use in one for a little while, get a bit of a benefit, then we go on to another one, and then we go on to another one. But the idea of switching off viral replication in a meaningful, sustained way didn't come about until about 1996. So I started my journey working in HIV medicine in the mid-90s, early 90s, 1993, in the time before we had really meaningful medication that we could offer to people. And so I unfortunately witnessed many people losing their lives to HIV. And when I was working in Dublin 8 in the Guide Clinic then, it was most of the people we were looking after had acquired HIV through injecting drug use. And it really was a family problem where we were seeing whole siblings, women, mothers and fathers losing all of their children to HIV. And it was a very, very sad time. There was a lot of despair around about this time where we really thought we're never going to get on top of this virus and improve outcomes and survival for people living with HIV. But then a big breakthrough came in the mid-90s, about 1996, when we got a class of drugs called protease inhibitors, which they were an absolute game changer. And we knew then that we could effectively switch off viral replication to ensure that the virus wasn't being ongoing attacking of the immune system, so that people could regain immunological well-being if their immune system had been damaged, or actually have maintenance of their immunological well-being if the virus hadn't actually attacked their immune system so much at that particular time. So that led into the sort of hit hard era, where we were actually trying to aggressively get people on, and I say aggressively, not anyway, we were trying to get people on medication as early as possible and as quickly as possible, thinking maybe we could actually eradicate the virus from people's bodies. And then two things happened. One, it became apparent is in the early 2000s, where it became apparent that actually we didn't have access to all areas where the virus was resident within a human host with the current medication we have. So there's this latent reservoir of virus that is in resting T cells that we can't get to with our current medication. So therefore, all the fancy modeling that looked at if you had a starting from this with your viral load and you get down to this, maybe you could eradicate, became a null and void conversation because we weren't actually able to eradicate the virus from these latent reservoirs. The other big problem was that the early medications that we were using for people living with HIV, whilst they conferred significant morbidity and mortality benefits, it often came with a price, sometimes the ultimate price, because the medication could be quite toxic. So that led us into an era of trying to find that sweet spot between not too much damage being done by the virus to when people really needed the medication. And in parallel, in the pharmaceutical industry, what was happening at this time was newer, better drugs were being developed. They were much better tolerated, much better side effect profiles, very importantly, much better drug-drug interaction profiles. So then it allowed us to move into the era of earlier initiation of antiretroviral therapy. And that was because not just that was because we were learning sort of towards the end of the 2000s and into the 2010 and on to now, we learned a number of things. One, that actually it wasn't just about your CD4 count. Having uncontrolled viral replication in a host is having the person's immune system in a constant state of alert, and that is actually quite tiring on the body. And this concept of inflammaging. So we knew that we had CD4 counts below which we were worried that people would get opportunistic infections. But actually, even when we had a good CD4 count and ongoing viral replication in the absence of antiretroviral therapy, that the individual was at risk of morbidity and mortality compared to an individual not living with HIV. So then we moved into the era of starting antiretroviral therapy as soon as possible. So that confers, we know that individuals who are on antiretroviral therapy as soon as possible confers individual benefit to them by switching off viral replication so they've got maintenance or restoration of their immunological well-being as much as is possible. And they have this switching off of this chronic inflammatory state where the inflammaging and the inflammation associated with chronic response to ongoing viral replication is turned off or switched down to a very significant degree. Really, really importantly at a population level is the fact that what happens here is that if you have individuals living with HIV on effective treatment, they will not transmit HIV to their sexual partners. And that's what has led to the statement U equals U. So that's where we are now, where we offer people treatment as soon as possible. And hopefully in the future, we will ultimately get a cure. And the reason I want to put this onto a timeline is it's a relatively short period of time. So between the early 80s and now, we've gone from a situation where there was an almost ultimate risk and outcome of death for individuals who are diagnosed with HIV to where now people can have life expectancy and survival rates similar to that of the general population. That is really, really fast in terms of how quickly things move in medicine. And if you think of the parallel of something else that's of very important public health import would be, say, breast cancer. So breast cancer was first described way before Christ. So back in 500 BC, there are reports of breast cancer. The concept of introducing surgery was introduced in the 17th century. So we are still now struggling with breast cancer and ensuring that everybody has the best possible outcomes for some aspects of breast cancer, despite the fact that we've been grappling with it for a much, much longer period of time. And so HIV has actually managed to get quite a long way down the road towards cure in a relatively short period of time. So this slide tells two very different circumstances. So on the left of the screen, you have David Kirby, who was a HIV activist who sadly lost his life to HIV in the late 80s, early 90s. And here he is pictured on his deathbed. photographed with his consent, surrounded by his family, who had initially he had been estranged from when he came out as being a gay man, and then subsequently to be found living with HIV. It's a very sad story. You can see that poor David is clearly very wasted in the bed, and he ultimately lost his life to HIV. On the right, a much different story of the very bubbly, very brave, and very much alive Aoife Cummins, who is a nurse working in Galway University Hospital in the AMAU, who is publicly living with HIV. And this puts shivers down my spine when I think about how far we've come, that you've got poor David on his deathbed, and we've got Aoife contributing to our healthcare and contributing to the workforce in a very meaningful way, now actively, openly living with HIV, knowing that her survival will be just that of the rest of the population because she takes her medication well and on time. And so they really, really need to highlight this, because people who are living with HIV still experience quite a significant amount of stigma. I'm going to talk a little bit about this towards the end of the talk around healthcare associated stigma for people living with HIV, which is something that I think we all need to sometimes reflect on the things that we say and how they may be perceived by the people who are at the receiving end of that information. So ultimately, in my view, this is a good news picture where we're moving away from the pictures on the left to the ones on the right. So what happens when somebody's infected with HIV? Usually within the first couple of weeks, they'll experience a seroconversion illness. And you'll all have had, oh, I've got something viral. And so that viral thing may manifest itself when you're infected with this particular virus, may manifest itself with fevers, sweats, myalgia. Some people experience a rash. Most people will have some lymphadenopathy. Sometimes people have oral genital ulceration, sore throat. And we've had people who've been extremely unwell with the lymphocytic meningitis requiring intubation and ventilation in ICU, or at the extreme end, down to the much milder end, which is like a passing viral illness, which is self-limiting. What happens during that phase is that an individual, so this is a timeline against weeks here on the x-axis moving out to years, and on the right in blue we have, or sorry, on your left in blue we have the CD4 count, which is how we well monitor individuals' well-being living with HIV, and the amount of virus per mil of plasma in red here. So around the time that somebody experiences their seroconversion illness, they have a very high burden of HIV. HIV is really good at making more HIV. It hijacks part of the immune system, which is what viruses do. They're not able to complete their life cycle on their own. So it hijacks part of the immune system, makes more virus. It doesn't have very good inbuilt quality control. So it actually just it wants the opportunity to make more virus at the expense of quality control. So it actually just keeps making more and more virus. And what happens is when an individual is infected with HIV, they will try to mount some immune response. And in the vast, vast majority of individuals, this is not a response that can eradicate the infection, but will ultimately lead to a balance being struck somewhere between the CD4 count, the immune system, and the virus. So the virus, the CD4 count, the immune system is trying really hard to get rid of this new pathogen in the body. There's loads of the pathogen around, and within a number of weeks, then individuals will have driven down the viral load to a certain amount. And what we call this is the virological set point. And it's kind of a moot point now, but back in the day when we didn't offer antiretroviral therapy as early as we do now, we tried to work out what somebody's viral set point was. And that was in this early battle between the virus and the host, where the host doesn't ultimately win, but can have some bearing on how much they can drive the virus down. We knew the further they drove down the viral set point, the slower it was somebody's natural progression to requiring to being at risk of opportunistic infections, and that could be up to years for some individuals. So we know that babies who are infected through vertical transmission and are being infected with HIV older in life, that these individuals were more likely to progress more quickly to having constitutional symptoms again following this period of clinical latency, opportunistic infections and death, versus younger people. So generally speaking, younger people could survive for 10 to 15 years unknowingly having HIV, and only with the benefit sometimes of hindsight to go, oh, well, I suppose I wasn't that good, and I did have more chest infections than I may have otherwise have had. So this natural history, which ultimately, unfortunately for individuals who are not on antiretroviral therapy, will ultimately lead to death, is now significantly changed, and with the advent of effective antiretroviral therapy, which affords individuals significant survival benefit and benefits and life expectancy approaching that of the general population. Just a little word on CD4 counts now. So the normal CD4 count for individuals is about 500, anything above 500. There's really no upper limit, but as we get older, we do experience immune senescence. So our immune systems do get tired and older as we go on, like every bit of us. And so our immune system may decline, our CD4 count may decline with age as well. Also, if I don't have HIV, but if I have a viral illness that isn't HIV, I may experience a temporary decline on my CD4 count and then bounce back up. So you would have seen, sometimes we see with people will have a lymphopenia with COVID, for example. That's the thing we would be most familiar with in recent times, that people who had experienced COVID, sometimes they'd have a drop in their lymphocyte count associated with the COVID infection. So when we're looking after individuals who have CD4 counts that have been affected adversely by HIV, we have a number of different thresholds. So when an individual has a CD4 count that's dropped below 200, we are then concerned that they're at risk of getting PCP, or now called PJP, so pneumocystis carinii pneumonia. And so in those circumstances, we will prophylactically put them on cotrimoxazole or alternative antibiotics to overcome the risk that they have of getting an opportunistic pneumonia like PJP, until such time that their immune system has recovered with sustained virological suppression. When you go even lower, in addition to needing PCP prophylaxis in individual when they go less than 100, for individuals who have been previously exposed to toxoplasmosis, like many of us have been, particularly through undercooked pork, they are at risk of reactivation of old toxoplasmosis. So when the CD4 count goes less than 100, that's what we're concerned about, and we offer prophylaxis at that point as well. Again, with cotrimoxazole will be our first line, or with dapsone and pyrimethamine in combination. When individual is even lower, they'll need PJP, toxo, and MAC prophylaxis if their CD4 count is less than 50. And these are really the categories that we are absolutely trying to avoid by having our HIV testing strategies and awareness of the benefits of testing for HIV. So when we have somebody who's presenting with a CD4 count that low, we will consider putting them on MAC prophylaxis, which is Mycobacterium avium complex. So an atypical form of mycobacteria infection, which can give a very chronic, unrelenting course in individuals. And until such time we get the CD4 count up with sustained virological suppression, we may put them on prophylactic azithromycin. We also need to consider that the risk of MTB, Mycobacterium tuberculosis, and we do offer latent TB infection treatment to individuals who have a positive IGRA, I should say, instead of MAN2 on the slide now, because we are mostly screening with IGRA. For individuals who have evidence of latent TB, we will actually treat them. For individuals who have a low CD4 count, we know that the risk of cervical cancer, which is an AIDS-defining illness, is higher than that of the general population. So individuals who have a cervix, who need screening, we offer annual screening up to the age of 65 and early recourse to colposcopy and biopsy in the event of a high-risk HPV positive screening test and then subsequent biopsies. And for individuals who have CD4 counts, regardless of CD4 count, we offer vaccination, particularly pneumococcal vaccination, to all individuals. And many of the patients we look after living with HIV are also current smokers, so they may be at risk of recurrent bacterial pneumonias as well. So when we see somebody with a diagnosis, in addition to trying to look at their CD4 count and the viral load, which is the amount of virus that's in the blood, and getting them on antiretroviral therapy as early as possible, we want to prevent and manage as many comorbidities as possible. So we know that individuals living with HIV are at increased risk of cardiovascular disease, renal disease, and bone disease. And this is in large part because of this process of the uncontrolled virological replication that may be going on in the chronic inflammatory process prior to the initiation of effective antiretroviral therapy. We are always looking to identify modifiable risk factors for patients living with HIV. And when I was speaking at the conference a couple of weekends ago for the conference for people living with HIV, I went on and on and on about smoking cessation, the benefits of smoking cessation. And anyone who sees me in clinic will know that that's one of my MOs. I will really like to talk about cigarette smoking, and not in a dictatorial way, but in a trying a supportive way to try and get people to a position of understanding the benefits and getting them onto a road of effective smoking cessation. And I know that's music to your guys' ears as well because of the benefits from a cervical screening perspective of smoking cessation, in addition to the many other benefits. Vaccination is a very important part of the care we provide to individuals living with HIV. And all patients are offered or recommended to have annual flu vaccine, vaccination against hepatitis A and HBV vaccination if they're not immune, pneumococcal, as I said, measles and rubella, and VZV, which is particularly important as we've had changes in the demographics of individuals presenting to our services in the last number of years, where they're coming from countries where there may not have been as robust vaccination programs. And certainly we would have seen more individuals who are VZV non-immune and measles non-immune coming to our care in the last number of years. And then for all individuals living with HIV up to the age of 26, we offer vaccination against HPV, recognizing the association between HIV and HPV, where there's an increased expression and prolonged expression of HPV and increased risk of HPV-associated cancers. And then for within the cohort of individuals living with HIV up to the age of 45, for men who have sex with other men, we offer HPV vaccine as well. Again, as I mentioned at the beginning, the importance of cervical screening for women living with HIV. So we offer annual screening, and up to previously there'd been no upper age limit, but now the age limit is at 65. So they exit the screening program if they've had normal screening there prior to this at the same age as the general population. Within our service, in James's, many of the women who we look after are not registered with a GP or have not disclosed their HIV status to their GP. So we actually do try to do their cervical screening for them. And wherever possible, we like to liaise with our patients' GPs because we want to make sure that we're all on the same page. And I might not be the best person for looking after somebody's dyslipidemia or their type 2 diabetes, categorically not. And so liaising with each other is a really important part of the prevention and management of comorbidities in individuals living with HIV. And this is particularly important as our survival rates for individuals living with HIV have improved, because we know that the age-associated comorbidities are more likely to, as our cohort is getting older, they're going to acquire the normal age-associated comorbidities that individuals get. And so really doing this in a joint way with GPs would be how we would like to do it, but it isn't always possible for the reasons I've mentioned. So then, with respect to antiretroviral therapy in Ireland, antiretroviral therapy has always been available free of charge to individuals living with HIV. The only criteria was that you had a confirmed HIV diagnosis. You didn't have to meet, and there was no means testing thereafter. It was literally that you just had to be diagnosed with HIV. And in recognition of the benefits from an individual perspective, and at a population perspective of preventing onward transmission, this was enshrined in a position published by the HSE back in 2017 and updated in 2023 with more patient-friendly language, which basically states that it is recommended that all individuals attending services in Ireland are offered antiretroviral therapy as soon as possible and informed of the benefits of antiretroviral therapy, improving their personal health and in reducing HIV infectiousness. So moving on a little bit more then to antiretroviral therapy. So what are our treatment objectives when we see people in clinic, when we're getting them onto treatment? Our first port of call is to get virological suppression. So we want to get switch off the virus replicating to a point where it can't in parallel attack the immune system anymore. So it's not a cure, but it's actually switching the ongoing attack on the immune system off. And the current thresholds we have in clinical practice are less than 40 or less than 20 copies per mil or not detected. And the clinical significance between these three measures is not meaningful as we understand it at this point in time. In order to do this, one of the things when we see people for the first time they come to see us in clinic, we'll do a baseline resistance test, because unfortunately with the advent of treatment and in the way that we use treatment in the beginning, we now know that there are some mutations in the virus that can confer significant resistance to some of the drugs and some of the classes of antiretroviral therapy we have. So everybody will have a baseline resistance test where we want to know what are the tools in our kit box that we can use for this individual to get them onto a regimen that will suit them best, to allow for virological suppression, which in turn will facilitate immune recovery and maintain immunological well-being of the CD4 count or restore it, where if somebody presents with a low CD4 count, we want to try and get a restoration closer to that 500 mark that I mentioned earlier. We also know that it reduces inflammation by switching off the by switching off viral replication to that level. We will reduce the inflammatory process and the inflammaging associated with that. And very importantly, it eliminates sexual transmission when we have ongoing sustained virological suppression, which has led to the very important statement for people living with HIV of undetectable equals untransmittable. This is a fancy diagram of the life cycle. So the virus as it encounters with the CD4 cell, and we can look at all the different stages around the life cycle of the virus that we now target with antiretroviral therapy. And in the beginning, we only targeted one area, and that's where we learned our mistake with the very early days, where we would start somebody on one drug that was only targeting one aspect of the life cycle. And so what we found was that individuals would have a short-term benefit associated with that. With some of the early drugs like AZT, that could be for up to 12 to 18 months of a benefit, and then the benefit was lost. And the reason that benefit was lost was because the virus had found a way around this particular blocking of the life cycle of HIV and had developed resistance to this particular agent. What we found in the mid-90s was that if we target the virus at a number of different areas at the same time, we can achieve sustained virological suppression, which is what our end game is now. And this just is to illustrate that we have lots of different target sites for the current drugs that we use in antiretroviral therapy for switching off virological replication and achieving sustained virological suppression. So if you think back to when I think back to the days where actually I even think back as far as 2002, when I sustained quite a significant needle stick injury and I needed to go on post-exposure prophylaxis for 4 weeks, I was on 5 tablets twice a day, 4 weeks, that needed to be eaten on a high-fat meal when I had the worst possible nausea known to God or man. And we were using these agents. So the drugs that we had in the beginning were really, really horrible for individuals to take, but they were their lifeline. And I'm sure if I had been living with HIV back then, I would have tried my absolute level best to take them because it was what was keeping people alive. Fast forward to now, to 2024, and this says 2022, but we have for many individuals, it's down to 1 tablet once a day, where the drugs within 1 tablet are available, packaged in 1 tablet, targeting the virus at different stages in its life cycle to achieve sustained virological suppression. And we now, in recent times, have available in Ireland to individuals 1 injectable agent. And the injectable agent is a combination of cabotegravir and rilpivirine in long-acting injection. So you can see there are 2 vials on the right of your screen there. So it is 2 deep IM injections, and it's given every 8 weeks. There are lots of people for whom this is fantastic. It isn't suitable for everybody. And I think for many individuals now living with HIV who are doing really well, who only need to come to see us twice a year, having to revert to coming to see us every 8 weeks may be a showstopper. But hopefully in the next couple of years, we'll get long-acting injectable agents that can be given less frequently. So maybe twice a year or even once a year would be wonderful for many of the people we look after living with HIV. So of all the different agents, and this is exactly the same slide I used for the conference that I was speaking to recently for people living with HIV. So what's the best one? The one that you can take that achieves virological suppression with minimal side effects and minimal drug-drug interactions. categorically the level of choice that we have now, beyond those, the picture of the single drug agents that I've referred to there, because we have other ones as well where some people may take 2 tablets a day, affords us the opportunity for very significant individualized care to suit the needs of an individual, to suit their metabolic profile, to suit their weight, to suit their comorbidities, to suit the other medications that they may be on. And as I mentioned, we have injectables currently available, and at the moment it's 2 monthly appointments by deep IM injection. So I mentioned that I would talk a little bit about life expectancy, and whilst this is a very busy slide, what it demonstrates, the bottom line of this slide is, and this is published from a series of different cohort studies looking at people living with HIV who did not have an AIDS-defining illness. So these are individuals who were pretty well. They had not had an AIDS-defining illness at the time of their follow-up. And they're stratified into women on the top, because women generally have a little slightly higher life expectancy than that of the general population, and men at the bottom. And looking at them in different CD4 count strata. So if you see here, on the bottom here, we have 0 to 49, 50 to 99, so different CD4 count strata. So you can see that the higher the CD4 count, the better the life expectancy approaching the general population of 45.8 additional years from 40 years to individuals here with a good CD4 count, which is about almost a 10-year drop if you've got a much, much lower CD4 count. You can also see within this some of the additional factors that have a bearing on individuals' life expectancy, and that is how they acquired their HIV. So we know that individuals who acquire HIV through injecting drug use have other factors that are contributing to poorer outcomes, and we know that their outcomes are not as good as individuals who have acquired HIV through other means. Now, the bottom line of this slide is that we need to be getting people on antiretroviral therapy before their CD4 counts are down here, so that everybody maintains themselves up in this CD4 count strata of greater than 500, so that they can have a life expectancy approach in that of the general population. And we're not doing that just yet. So we know, this is just turning to the epidemiological data, which were published in November of last year for the 2022 figures. And in 2022, we saw a 68% increase in the total number of individuals who were diagnosed with HIV in Ireland for the first time. A very significant proportion of these individuals had come to Ireland already with the HIV diagnosis, and many of these individuals had fled from war-torn parts of the world like Ukraine. So we had a very significant increase of the profile of individuals coming to our care, many of whom had already got a HIV diagnosis. So they didn't acquire HIV in Ireland, they were already living with HIV. But this had a very significant impact on the services that we provide, and it has been quite difficult to ensure that we can afford the same level of care. And I'm sure many of you will experience the same thing, where it's been really big challenge to meet the needs of individuals, where culturally we have many differences, and we have other, in addition to cultural differences, they come from different healthcare systems and they expect things to be different in a different way, and we expect to deliver things in a different way to their home country. But basically, bottom line is here is we had a significant increase in the number of individuals who we needed care in Ireland for living with HIV. And actually, you can see here that I'm actually going to go on to the next slide. Oh, sorry. What I wanted to show here was about that key thing about the CD4 count. So if you take, when the HPSC were preparing their end of year reports for the 2022 HIV figures last year, they published it by the first time ever had a HIV diagnosis in Ireland, and the first and all HIV diagnoses, because the way the HIV diagnoses are reported is it's a laboratory-based notification. So if I came from Ukraine, for example, with HIV to Ireland, and as part of my baseline assessment, I had a HIV test, I would be counted in those numbers as a new HIV diagnosis, although I'm not, in fact, a new HIV diagnosis. I am a new to Ireland HIV diagnosis. And when we look, they split that out in the report that they published this last year. And you can see that of the individuals with a first-time diagnosis in Ireland, the late diagnosis, which is a definition where the CD4 count at time of presentation is 350 or less, was 45%. So about 1 in 2 of the first-time diagnoses that were reported to the HPSC in 2022 had evidence of some destruction and some harm to their immune system at the time that they were presented. And this figure hasn't really changed significantly over the last number of years. And what this says to me is that we actually need to do more about raising people's awareness of the benefits of knowing their own HIV status, and also for us as healthcare providers to be more open to offering HIV testing to individuals. And with that, I'm going to move on to a little bit about HIV testing and this phenomenon of HIV indicator condition-based testing. And this is a really useful resource. You see the link on the bottom of the slide there, where we know that there are a number of clinical circumstances in which the individual's presentation is associated with an increased chance of being HIV positive versus the general population. And there is good epidemiological data to prove that. And these conditions then are called HIV indicator conditions, and they're divided into three categories. One, conditions that would be considered an AIDS-defining illness in an individual living with HIV, and for of relevance to cervical screening audience is that cervical cancer is included in that HIV/AIDS defining condition. Category 2 then is non-AIDS defining conditions which are associated with an undiagnosed seroprevalence of greater than 1 per 1,000 in the population. And I have some more tables on this in the next couple of slides. And then there's a third group, and it's conditions where not knowing somebody's HIV status could be really harmful, because you may be about to start them on medication that is going to harm their immune system. So knowing that their immune system may already be compromised is an important part of the provision of care. So for example, if we're starting people on disease modifying agents for rheumatoid arthritis or other conditions, and or chemotherapy, for example, where we may be harming their immune system with the medication that we're using to benefit some other condition, knowing whether or not their immune system is potentially compromised with HIV is an important thing to bear in mind. So then moving back to category 1, which is the AIDS defining condition, and you can see in here included in this is cervical cancer. And I would hope that individuals who are diagnosed with cervical cancer are automatically offered a HIV test. Non-Hodgkin's lymphoma is an AIDS defining illness. And really all lymphomas is an increased association with all types of lymphomas and being HIV positive. So any individual diagnosed with any sort of a lymphoma should be offered a HIV test. And these are a number of other conditions that are actually AIDS defining, in whom individuals are strongly recommended to have HIV testing. And that's a little bit more straightforward. It's clear this is an AIDS defining illness. But let's move on to the next category. The next category, which is conditions associated with an undiagnosed HIV prevalence of greater than 1%, or conditions considered likely to have an undiagnosed HIV prevalence of greater than 0.1%. And in the ones on the left of your screen, strongly recommended having HIV testing included in this is anal cancer dysplasia, cervical dysplasia, infectious mono-like illnesses, unexplained leukocytopenia, thrombocytopenia, seborrheic dermatitis, really bad seborrheic dermatitis, atopic eczema, invasive pneumococcal disease, and then we do know that on the right-hand side, we have an increased risk of lung cancer independent of smoking factors in individuals who are living with HIV. So offering HIV in those circumstances is important. And whilst I'd love to spend about an hour and a half going through each of the particular things listed on this slide, again, I'd like to draw your attention to this very useful resource, which goes through not only the data that they have to support these statements, but also mechanisms and how you might go about offering an individual a HIV test. And that's all with the endeavor of trying to normalize HIV testing, because we all have a HIV status. Everybody has a HIV status. It's for individuals who have a positive HIV status that we really want them to be afforded the opportunity to get on treatment so they can have the life expectancy that they could have with effective early treatment. And again, this is the conditions where you may be harming the immune system with the medications that we're using, and where it would be important to know that there's something else compromising the immune system at that time as well. I mentioned about the slides that looked at the different strata of survival and life expectancies for individuals living with HIV, and how injecting people who'd acquired HIV through injecting drug use were singled out here. And this goes back to the importance of the social determinants of health. So the things that beyond actually having the condition that are important for determining people's individual outcomes. So their socioeconomic status, their social supports, neighbourhood and built environment, health behaviours, access to healthcare, discrimination and social inequalities, and people living people living with HIV still experience quite a bit of social stigma within the general population and also within healthcare settings, which I'm going to draw on some work that was done by Dr. Elena Vaughan in the University of Galway in the last couple of years, which showed some very stark figures around the outcomes of her study looking at healthcare associated HIV stigma. But again, I suppose this highlights the importance of considering the individual in their entirety and not just the particular disease. So for example, if I am a woman in her mid-30s with 4 kids, unsupported, no housing, no transport, nobody to look after my kids, going to my clinic is actually probably going to be very low on my list of priorities. So considering people in the more holistic ways is generally how we try to approach HIV care and to ensure that nobody is left behind in the quest to get the best possible outcomes for everybody. So moving then to the other bit that I wanted to talk about was what's going well and what's not going well. So clearly we have come a very long way in a relatively short period of time to having really good medication for people living with HIV, with much more favorable adverse event outcomes profiles and much better outcomes. So literally, the more people you have on treatment, the fewer people will get sick and the fewer people will die. We have a much closer experience of life, of normal life, whatever that may be, for individuals living with HIV than we did a number of years ago. And that's manifest by, for example, now for people living with HIV, parenthood is a consideration for them. Whereas back in the early days, we would have been very concerned about the risk of vertical transmission of HIV, and we would have dissuaded parenthood. Now we're in a position where actively, I will proactively bring up with patients in clinic, like, would you consider a pregnancy? Would now be a time to consider a pregnancy? And it's amazing. I'm still amazed at the number of individuals who say, oh, I just assumed I couldn't have kids. What do you mean? And you think, well, actually, we go through the data that actually we can do quite a lot to avert vertical transmission of HIV, such that we now actively encourage people who may consider consider becoming a parent or becoming pregnant, that they would actually go for it before time runs out, when our biological clocks start to tick even louder. So parenthood is a relatively normal outcome for individuals. And to parenthood, I say, scarred by having 3 young adult kids myself. Mortgages. So now individuals living with HIV can get mortgages. And they very recently, through the support of HIV Ireland, which is a very important NGO that provides support and care to individuals affected and living with HIV, that they can actually get life protection that is the same as that of the general population. We're moving much, much closer to breastfeeding for mothers living with HIV who choose to breastfeed their infants. Back when I began on this journey, we would have been absolutely recommending against breastfeeding. We are now supporting some women to breastfeed their infants in a very controlled way, because we've got very little data in our hands around doing this. So it's still quite controlled and quite a lot of monitoring for individuals who choose to breastfeed. But 15 years ago, we would have been saying categorically, do not breastfeed. I'm very happy to say that one thing that is going well is that there's much greater focus on women and the outcomes of women and other underrepresented groups in studies and considerations in how we structure our care than there were in the past. And that is a really welcome thing. I was at a meeting in Warsaw in October, and the number of sessions that were talking about women and the outcomes in women was really, really much greater than it had been before. There's a very important focus on aging and HIV, and that's particularly important because as people's outcomes improve and they get the normal aging associated comorbidities that come with getting older, we need to understand how they play out in the hands of an individual who's living with HIV. And within our service in James's, we have a platinum clinic where individuals over the age, of 65 can be assessed in the Med-El service. We are providing a joint service to those individuals because we fear that they may be at greater risk of frailty than the general population. And we want to try and track that and avert any ill health that we can, so that they successfully age living with HIV. Fast Track Cities is an initiative where trying to get to zero new transmissions of HIV within a city. And Ireland signed up to the Fast Track Cities initiative in 2019. The Government of Ireland signed up to that initiative in 2019. Within the programme, my colleagues Caroline and Rachel are finishing a very large piece of work of scoping out the needs at a city level, from a healthcare service, from a support service, from a city infrastructure perspective, for the needs of individuals living with and affected by HIV. And that should be published by the end of this quarter. And it's something that hopefully the recommendations from that will be implemented, because it should go a long way to ensuring that, one, we get to zero new infections, but also that we go a lot closer to ensuring that nobody gets left behind, that everybody can be afforded the benefits of effective antiretroviral therapy. What's not going quite so well is the stigma thing, but I go back to the slide of Aoife at the beginning, who, I mean, she's so brave, an amazing woman who is openly living with HIV because she was so fed up with what she was experiencing. And nobody was overtly being discriminating, but it was soft things that people were saying. She's like, oh my goodness, I'm living with HIV. Did you think I'm different to anybody else? So I think that we are coming towards a better position for individuals living with HIV not experiencing stigma, and that is manifest that people are advocating and for themselves, which is great, but we still have a fair bit to go on that. One of the really sad things is that we for people who experience subfertility, it is a really big challenge for them not being able to access IVF or ICSI in Ireland, because of the requirement that potentially contaminated specimens need to be housed in a completely different laboratory to the general laboratory specimens. And that is a challenge that I don't see us overcoming too soon, but we do work in collaboration with a number of centres across Europe to try and support couples as best they can in navigating the often roller coaster journey of achieving pregnancy and parenthood. Just a little bit about stigma. I don't know how I'm doing for time. A little bit about stigma. So one of the UNAIDS HIV prevention targets is that by 2025, that less than 10% of people living with HIV and key populations experience stigma and discrimination. And I'm indebted to Elena, University of Galway, for providing me with these slides. So to understand healthcare-associated stigma, Elena conducted a study which was published in the last quarter of 2023. And she did a survey of people living with HIV and a survey of healthcare providers. So the sample size is 89. It is not 98 like it says on this infographic here, and Elena apologizes for that. But what were the key findings for the people living with HIV in this survey? So mostly, the first thing to point out is that they were mostly men, and mostly over the age of 40, most of whom had full-time employment, all of whom were on treatment that was working. So these were people who were doing relatively well. That said, almost 1 in 5 reported they had been denied some sort of service in the past 12 months because of their HIV status. 1 in 4 said that healthcare workers use precautions in excess of usual measures when providing care to them. And 1 in 4 almost have been told to come back later or made to wait or put at the end of the list because of their HIV status. 1 in 2 avoided healthcare facilities for worry that they will be treated differently by healthcare workers because they're living with HIV, which is really quite shocking. And 58% avoided seeking healthcare for feeling ashamed about their HIV status. And there should be no shame for individuals living with HIV, because this virus just doesn't care who it infects. So it really saddens me that that 58% of the respondents to this survey experience shame because they're living with HIV. Turning to the survey that was done on healthcare workers, and there were 298 responses. Things that I want to draw your attention to is 23%, so almost 1 in 4, disagree or did not know about U equals U. Now, you can't really disagree with the data because the data is there, or did not know about U equals U, which is that when somebody's on effective treatment, they will not there is no risk of onward transmission of HIV, particularly through sexual contact. I think it's really telling that 13% will wear double gloves in providing care. Almost 1 in 3 will wear gloves during all aspects of patients' care. We need to be able to shake hands with our patients, and we don't need to be wearing gloves or even double gloves in order to do that. And 1 in 5 will use special measures they would not use with other patients just because somebody has HIV. So the recommendations arising from this very important work that Elena did, or that we provide education and training to healthcare professionals, that there are policy and practice guidelines in place to ensure that those recommendations follow through so that individuals don't experience stigma in the healthcare setting, that we raise awareness at a public level. And there is actually a big HIV stigma campaign going to be done by the HSE later this year to raise awareness around HIV. And also we continue to conduct research like this to understand whether or not the interventions we're putting in place are actually tackling HIV stigma, and particularly healthcare-related stigma. So what is it like for me as a doctor? I don't have blonde hair. I never had blonde hair. But for me as a doctor looking after people living with HIV now, what do I think of when I see somebody newly diagnosed with HIV? Such great treatment, 1 tablet once a day for the majority. I need to be able to work with people to enable them to be adherent to medication, often addressing some complex psychosocial circumstances. And we need to see people as early as possible to ensure they get the best possible life expectancy associated with their HIV, in parallel to actually preventing as many HIV infections as we can. And that's a subject of a totally different talk now about it, preventing new HIV infections. What are patients thinking about? Will I die? What will people think of me? Do I need to keep this a secret? And secrets are bad for us. It's well known psychologically that secrets are actually bad. And if you have to engage in lots of different channels to try and keep something a secret, it actually can be quite aging on us and quite hard on our bodies. Can I have children? Could I breastfeed? Will I infect my partner? Could I ever have sex again? They're the kind of things that people think of when they're coming to see us in clinic. So with that, I'd like to thank you. And this is just a slide of an image of the red ribbon, which is our symbol for advocacy for people living with HIV, which is projected onto the walls of the City Hall back in Warsaw in October when I was at a conference there. So thank you very much for the time.
Fiona, thank you so much. Fiona, I just have one question coming in there in relation to the pneumonia vaccine. You had said that it needed to be given more frequently.